Well, we'd like to introduce Dr. Kofi Essel, who I had the privilege of training with at Children's. And for those of you who haven't seen him, because he often speaks on this topic and has really become a national leader on obesity management and food insecurity, and I'm proud to introduce Kofi and to kick off our conference today. All right, Dr. Essel.
So thank you all for being here. We're here for shared learning. We're here to help each other in practice. We're here to help our kids and community. Dr. Essel, kick us off.
All right, everybody. I'm excited to be here today to talk about this topic. It was actually about 9-10 years ago that I was able to be on this stage last time to do a talk on energy drinks. I see some friends in the back. Let's go ahead and get dived in. All right, so what is the topic today? What are we doing? We're setting the stage to talk about this topic of obesity and pediatrics. What's the mindset? What's the framework we should have when we think about this topic? How do we engage this topic effectively? That's what I really want to spend some time talking about today. I want to share a few scenarios that I experienced that hopefully can get you all warmed up to understand what we're going to be getting into today. A few years ago, February 28th, 2021, around 7:40 a.m., I received an email from a great colleague of mine. The email said this: I saw one kid on Thursday who had gained 90 pounds in the last year, one who had gained 60, and 3 who gained 30 to 40. Their age range was 6 to 16. Is counseling about healthy eating and exercising really sufficient for this? They all have or will have, when they come in for their fasting labs, elevated hemoglobin A1Cs. Can endocrine clinic really handle all of them? You can hear the frustration, you can hear the anxiety, you can hear a bit of ambivalence, you can hear some fear, right? There's a lot of this kind of feeling that's around the room. 2 years also, we started to notice something else that was occurring about 2 years ago. You started to see some images, some cards that were given out in adult clinics. Has anybody seen these cards before? I got a few hands in the room. These are called Do Not Weigh Me cards. Let's read through this card. So, please don't weigh me unless it's really medically necessary. If you really need my weight, please tell me why so that I can give you my informed consent. Why? Because most health conditions can be addressed without knowing my weight. When you focus on my weight, I get stressed. Weighing me every time I come in for an appointment and talking about my weight like it's a problem perpetuates weight stigma. You start to see this being handed out in adult clinics. And I would argue that it's only a matter of time before we begin to see this in our pediatric spaces as well. Now, it's interesting when you explore this a little bit more. One of my colleagues a few months ago sent me an Instagram image or whatever they call it. I don't use Instagram, so whatever the Instagram thing is. And an influencer said something really interesting. Let me show you what she said. So this is an influencer. It's hard to read it, but let me sort of bring it to context. No child should be made to feel that their body is the wrong size. Kids are very literal, and that quickly can turn into I am wrong. They said that they do some things as they prepare to go into their clinician's office, especially with these new AAP guidelines that came out. There are 3 things that they highlighted that they do. Let me highlight these 3 things for you. Number 1, we message the provider the day before, mentioning that we're coming and that we request to not discuss weight or BMI during the appointment in front of the child. If there is a concern, they are welcome to message us after. Number 2, I bring a Post-it that says, please do not discuss BMI or weight during this appointment. I hand this Post-it to the doctor when they walk into the office. I have a hard time speaking up in this doctor-patient dynamic relationship. This gives me some confidence, some power to be able to do that. And the last thing they said is this: if weight loss or gain or BMI come up, I plan to interrupt and ask that we save that discussion for after the appointment. I may also ask, can we talk about milestones that are unrelated to body size? These are the experiences that a lot of you have shared, a lot of you have voiced, and there's increased frustration, anxiety, and worry. Should we be doing this at all? There's some questions that people have brought up, and some of those questions look like this. How did we get here? What did we do wrong? Should we even be talking about this topic anymore? I would argue this. The response that we've seen with these images, with these posts, with these cards that have come up, has been a response to what? Us not creating a safe environment for our patients, right? Us not providing an environment that's composed of dignity and humanity. As a result of that, patients had to take this into their own hands to protect themselves, right? You may say, well, it's not me. I do a great job of doing this. Well, I'm not talking about you then, right? You're a colleague maybe. But at the end of the day, you got to think about, what are we doing? How are we creating an environment? What is our posture to be able to talk about this topic? Today, I want to do two things. We want to talk about, number one, explore pragmatic reasons why we must discuss this topic of obesity. Number two, we want to identify the posture of empathy needed to discuss this topic of obesity. I start with an exercise that I learned from one of my good colleagues at the Obesity Action Coalition. She does an exercise where she says, hey, you can look up different things on Google, images in particular. You can look up cancer, different disease states, and you'll see different pictures that pop up. What happens when you look up obesity? What do you see when you type in obesity on Google Images? Now, this has gotten better over the years, but there's still certain things that we see time and time again. Let me show you some of those images that come up. What you may notice here in these images is what? You don't see any heads, right? You see images of body parts, backsides, bellies, right? You may see individuals eating a lot of different kinds of foods. This is the standard that you may see. You look at newspaper clippings, you look at B-roll or background footage on the news at nighttime, you'll see these same images coming up over and over and over. But what about children? What are we seeing with children? Here are some of the images we see with children. You see sometimes heads cut off. Typically, you'll see a picture of children eating some sorts of food, sort of exhibiting sort of gluttonous behavior, right? Eating cake or burgers, or you see oil or drippings of cheese sort of dripping down their clothes. These are the standards. These are the images that we've seen time and time again. But what about at the public health level? At the public health level, which a lot of us sort of work in both of these areas, what do we see? Well, it's not really any better. I'll give you an example from our teammates at the Children's Healthcare of Atlanta. What did they do? This is the Stop Sugarcoating It campaign that many of you may have seen years ago. This happened in Georgia, but what did they do? They put up images on billboards all throughout that said what? You need to be aware of your child having obesity, because if you're not aware of it, how are you going to know to do something about it? So they put up these great images everywhere so people could respond to. But the question you have to ask yourself is, what happened as a result of this? How did other children look at other children with larger body sizes? How did this influence parents or adults, how they looked at other children or other adults' children? How did this affect their own children, their psyche? We have to ask ourselves these questions when we do this kind of intervention. The VP at the time said something really interesting. She said this: it has to be harsh. If it's not, nobody's going to listen. This is what we have to do. And some of you may say, well, we need to be more direct. We're being too passive now. The question is, how effective is this as a tool to talk about, to address, to discuss this topic of obesity? Now, I'm going to ask you all a question, and I want you to tell me what words come to mind when you saw those images. Can you give me a few words that come to mind? Anybody? Somebody said what? Gross. Okay, I heard a word gross. Anybody else? Shame, sad. One more word. Blame, right? These are all powerful words that would describe what we saw. Some of the words that I thought about that came to mind were these. Number one, dehumanizing. Number two, belittling. Number 3 and 4, humiliating. Number 4 was stigmatizing. And the last but not least was this: strategic and intentional. These were done on purpose. These were very intentional. And one of the things I always ask myself is, what if we looked at individuals with larger body sizes in a different way? What if images looked something like this, where individuals, you could see their heads, you can see them doing activities or doing day-to-day things, having it fun, enjoying life. What is it that we are trying to do? Is it that we are trying to demonize obesity, or are we demonizing people? This is the question we must ask ourselves, what posture we're going to take in addressing this work. I start off with this definition here. What is obesity? How do we define obesity? Well, a lot of times we use obesity as a simple definition, looking through calories in versus calories out. This simple lens, right? Obesity is simple. Calories in versus calories out. About 3,500 calories equals 1 pound. So if I consume about 500 extra calories a day over a course of 7 days, I'll gain about 1 pound a week. If I decrease my caloric intake or increase caloric expenditure about 500 calories a day over the course of a week, I'll lose about 1 pound a week. One of my colleagues in the room, we know a patient who was on this course. Dr. Tuck, you remember Gregory? Gregory, 250-pound-year-old child, 250-pound child, and we got them on a great system. They were decreasing their caloric intake about 500 calories a day. Over the course of about a week, they were decreasing about 1 pound a week. Over the course of a month, you know what happened. Over the course of a month, they lost about 4 pounds. They kept doing this over the course of weeks. Over the course of a year, they lost 50 pounds. They did a phenomenal job, and they kept this going. They did this for about a year, 2 years, 3 years, 4 years. They even did this up to 5 years, and you know what happened. Their obesity was gone. We eliminated their obesity. This was not a condition anymore that we need to worry about. And I'm not seeing the responses I thought I would see with this. But the reality is, we often look at this and say, this is how simple obesity is. And I say this in jest because we treat it as simply, if you just restrict calories, if you do these simple things, everything would be fine, treating the body as a closed system. But the body is not a closed system and does not work this way. And I'll give you an example of what I'm talking about. One of America's favorite shows, The Biggest Loser. Anybody familiar with this show? Biggest Loser. Individuals would go on this TV show, went off air, came back on air. They would go on this show oftentimes up to 30 weeks, and you saw these dramatic changes that occurred, right? Extreme weight changes that occurred. You said, hey, how did this happen? Well, clearly it's because they did what they needed to do. And if everybody else did this, they would be able to achieve these goals as well. Now, I don't get a chance to watch a lot of TV, but I watch reality TV here and there. One of my favorite things about reality TV are the reunion episodes. Right? One of the questions you must ask yourself is, have you ever seen a reunion episode for The Biggest Loser? What happens when those lights went off? What happens when the cameras turned off and people went back home? That's the question you must ask yourself. One of our colleagues and great researchers at NIH named Dr. Kevin Hall did a really powerful research study on this. Looked at individuals who were on The Biggest Loser 6 years after they concluded. And what happened? What happened as a result? They explored this. They put this work out, and the New York Times really took this in, and here's an image that was on the New York Times. This image really gets at what is going on with this experience of obesity, in adults in particular. But they looked at about 14 contestants, and what did they see? On the left side, you can see something really interesting. On the left side, you can see baseline weight 0, and then what happens over time. Everybody lost a significant amount of weight. Everybody did. But the majority of individuals gained weight back. You see this common experience of the grades not showing up too well, but there's a check mark that occurs that with all of these individuals for the most part. The majority of them were able to keep off about 5 to 10% of their weight, which is associated with significant cardiometabolic improvements. But in general, what we saw is that from that baseline weight, everybody lost weight and the weight came back. And of course, the thing is that we automatically think oftentimes is, well, clearly they're not working hard enough. They just need to do better. They need to do what they did on the show and everything would be fine. They clearly went back to their ways that they were living before, lazy, non-compliant ways that they were doing before. Look on the right side. On the right side, you see what happens as a result of this significant weight drop. You see what we call of a slowing of metabolism, the baseline metabolism. Over time, individuals' metabolism slowed down significantly. Look at this individual here. Their body was burning 800 fewer calories a day. Their body was doing everything it could to regain that weight. It made them more tired. It made their satiety hormones decrease. It made their hunger hormones increase. It did everything it could to get back to that state of homeostasis. We call this the set point theory or metabolic adaptation, where the body will respond to these weight changes to get back to the state before. We need to understand obesity as far more complex than this simple model of exercise and diet. Exercise and diet, and instead be more like the group out of the UK, which brought over 300 experts together, the UK Foresight Committee, and designed a more simple, a more clear and realistic model of obesity, something more like this. Understanding the metabolic demand, understanding the reality of obesity, a chronic multi-system disease that requires what? A multidisciplinary approach. We cannot get simply stuck on calories in versus calories out through diet and exercise, but we have to understand there are a multitude of other things that go along with obesity. Think about it. Anorexigenic and orexigenic pathways. I'm not going to go into that. Don't worry. We can think about set points and metabolic adaptation. We talked about that. Genetics and epigenetics, what's turned on, what's turned off. The altered food supply, not only the quantity of food, but the quality of food. Ultra-processed foods, how it affects the microbiome. We can think about decreased physical activity, which not only affects caloric intake or burning, but also our muscle gain, which also has an association with calories as well. Stress and distress, cortisol level, insulin levels, right? Drugs, medicines that we give ourselves are increasing weight for our patients, but we're like, no, it doesn't do anything. But it actually does. It actually can change the set point. Sleep, right? Social risk, food security, housing insecurity, racism, all these things have a huge role on the stress, on the weight of individuals. So we have to understand that it's not as simple as diet and exercise. That's an important piece that we want to walk away with. Now, there was a model I was going to add in here, but it was too late. And it showed, hey, I do this course for my students for the last 8 years. I've taught them every year, gotten to detail about this. It's a premier course on obesity that we get a chance to talk about. Every year, all 180 students, they get this course, they learn all these things. 1 or 2 students come afterwards. They say, I know you talked about all that, but it's really diet and exercise, right? Look at me, right? Like it's really diet and exercise. And if you look at the last 20 years, our caloric intake has actually decreased, but we've seen weight increase significantly. What is going on? It's not just diet and exercise. I can't emphasize that enough. Now, the OMA has a great definition for obesity that I wanted to highlight here. A chronic, progressive, relapsing, and treatable multifactorial neurobehavioral disease, wherein an increase in body fat promotes adipose tissue dysfunction. So the adipose tissue, there's something going on with it. And abnormal fat mass physical forces. So the fat mass can result in damage to the body in addition to that adipose tissue being out of norm. This can result in adverse metabolic, biomechanical, and psychosocial health consequences. They also say this: while the BMI may be sufficiently diagnostic for populations and many patients, it is not the most accurate assessment for adiposity, which is what we're talking about when we're talking about obesity. I don't know if anybody saw this, but the AMA recently said, this was I think last week or the week before, they said what? We're going to devalue the emphasis on BMI. It doesn't do what we need it to do. We know that there are differences in BMI based on ethnicity, based on where that weight lands. BMI doesn't tell you the difference between bone and muscle mass versus fat mass. There are things about it, but they also said this: we don't really have much better for children. This is kind of the gold standard we have for children in the clinical spaces. We have other tools that Dr. Vadia and other team members are using, but in the clinical settings, in primary care, BMI is what we have. But we have to understand it doesn't always tell the whole story. So getting caught up on what we see in front of us and not understanding the focus on health is a disservice to our patients and our families. This is harder to see, but let me show you this really quickly. There are 2 things that I want you to think about when you think about obesity, because again, I think it's easy to get caught up in the narrative that we're seeing in social media nowadays about, well, weight doesn't mean anything. There's nothing that we need to worry about weight. Weight is just, everybody's just different sizes. There's truth about that, but then sometimes there's not truth. And let me show you what I mean by that. Look on this side. You can see where the fat tissue are starting to become dysfunctional. So you can see as a result of this, it can result in elevated blood glucose. You can see blood pressure changes, dyslipidemia, other things can happen as well. But on the other side of this, you can see what happens as a result of the physical force of that increased adiposity as well. You can see the stress on joints, immobility, tissue compression, sleep apnea, GERD. You can see the fat mass pushing on kidneys, increasing blood pressure. There are other things that can occur as well. So sometimes the weight itself can be a concern to patients and families, and that's something we need to think about as well. Now, we've talked about obesity, but the question is also, what is obesity bias? Something that we often, now you're hearing more and more about, but we need to understand this at another level as providers. And let me show you and break this down a little bit more. When I talk to my students about this, we talk about 3 different categories: bias, stigma, and weight discrimination. They're actually different, but we use them all interchangeably. When I talk about bias, I look at 3 kinds of bias. Number 1, what I call explicit bias, attitudes or beliefs about individuals with larger body sizes, right? Attitudes or beliefs. These are conscious attitudes or beliefs. Implicit bias, unconscious or subconscious attitudes or belief, right? Self-directed or internalized weight bias. We've done this enough, we say enough things, and individuals with larger body sizes start to believe negative things about themselves as well. Our role, what we say matters. These things influence how people view themselves as well. What about stigma? A social devaluation creates an us versus them category. A social devaluation, right? That's what we see with stigma. And lastly, this idea of weight discrimination, sort of overt forms of weight-based prejudice. Now, I won't leave you there. Let me show you the continuum of what I kind of talk about. I break it down in this continuum. Bias leads to stigma, which leads to discrimination. How so? Weight bias. Individuals with obesity are lazy, attitude or belief, right? Self-directed. I am lazy because I have obesity, right? Stigma. Individuals with obesity are lazy and are unlikely to follow my or be compliant with my instruction like my thinner patients over there. They know what to do, right? Social devaluation, us versus them. Weight discrimination. Individuals with obesity are lazy. They're not going to follow my recommendations. So you know what? I'm not even going to share this information with them. I'm not going to do a full exam. I'm not going to do X, Y, and Z because why? They're not going to listen to what I say anyway. Look at what they've let happen to their own bodies, or look at what their parent let happen to them. Weight discrimination. These are things that we say, these are things that we do, and I'll dive into that a little bit more with a case study. Let me share a case study with you. Here's some words that come up oftentimes when some people have described individuals with larger body sizes. Non-compliant, unattractive, dishonest, poor hygiene, low self-esteem, weak-willed, less intelligent, sloppy, lazy. And of course, who said these words? We did. Physicians have said these words. When you pull the data together, these are words that we often describe with patients with larger body sizes. This is what we often say. And of course, when I share this with my students, what do they say? They say, how dare they do that? Why would they ever do that? I'm never going to be like those doctors over there when I become older. The reality is, this is something that I had to help them understand about themselves as well. What did I do? I did an exercise. I said, hey, all of you 180 students, I want you to do a test called the IAT, the implicit association test. Again, subconscious bias. Do this test that associates what your perspectives are on individuals with larger body sizes. I got this example from one of my colleagues at Georgetown. I then made them reflect on their results. And that was what was incredibly powerful. What happens when they reflected on their results? Here are some of their results that they had. So if you look here, the majority of students, about 76% of them, had an automatic preference for thin body sizes over larger body sizes. About 15% of them, or 10%, had an automatic preference for larger body sizes over thinner body sizes. And then about 15% of them had no preference at all. So what do you see? You see this automatic preference that occurs. And the reality is when you look across the country in larger studies as well, you see the same pattern. More than 70% of students, medical students at that, have this high stigma or implicit bias towards individuals with obesity. The reality is we have the same results as well. And I want you to take a second to look at some of their responses, because when we have these students, these amazing students who have these amazing backgrounds, who come into med school with this powerful view of themselves, when they're confronted by their own bias, what happens as a result of that? You can imagine. I'll give you some examples. The first thing students said, of course, was this idea of denial. I'm skeptical of this result. I found this test instructions rather confusing. Therefore, I don't necessarily believe that the IAT weight is the best measure of a person's attitude towards overweight people. There's got to be something wrong with the test. It's not me. You know, look at me. I came to medical school. I'm one of the leading candidates around the country, and that's why I was accepted to this program. It can't be me. Another perspective, this idea of uncoupling one's explicit and implicit bias, right? At the same time, I strongly believe that I have a strong capacity to treat individuals with dignity and respect, no matter how I view that patient, whether consciously or subconsciously. I have this uncanny ability, unlike everybody else, I have this uncanny ability to separate my internal perspectives from how I treat individuals. Number 3, overt bias, right? I should clarify, I don't think someone being obese means that they're bad people or less deserving of healthcare or other basic human rights. I do think it means that they don't really care about their health, or they're just less informed about health issues related to obesity, which does make me judge them a bit on that front. I think a little bit of stigma against obesity honestly wouldn't be the worst thing. If anything, it would serve as an incentive for people to lose weight. This is the perspectives of the next generation of providers, in addition to our perspectives as well. Again, you look at them, you say, why would they say these things? You hold the mirror up to yourselves, and I want you to think about what category you would find yourself in. I have one more category for you. I call this rugged individualism. Individuals who have achieved great standards based on their own perspectives on their weight, and as a result of it, they feel they are empowered to talk about other people. Let me show you what I mean. Having been overweight myself and having the ability to gain control of my life and lose the weight leads me to believe that everyone can do the same. Or, my senior year of high school, I weighed 300 pounds. I struggled with yo-yo dieting for years before I managed to lose over 120 pounds. I feel a great deal of compassion and sympathy for those who have struggled with obesity, but at the same time, I will never be able to agree with the attitude that it's not their fault, or more importantly, that it's not their responsibility to change it. If we don't check our bias, how does it affect our care for our patients and the families that we see? This is an important thing that we have to think about. Now, something that's really important to understand is that weight sigma is not a great tool for weight loss or improving a patient's health, but it's a dynamic tool. It's one of the most powerful tools that I've seen for what? Worsening depression, associated with binge eating, avoidance of physical activity, weight gain, and also parental or caregiver distress. Why? Because the parents see how we look at them when their children are gaining weight. The parents feel that. What does the data say that the parents say? They say this. They feel a sense of isolation. They feel blame. They feel this concern about the health of their child. They internalize that self-blame. And they also feel that sometimes they worry that their providers are going to think they're being neglectful towards their child. They may take their child away from them. There's anxiety, there's stress, there's worry walking into those rooms. This is a concern that parents have. I'm landing the plane, don't worry. Here's what I want you to see. There's a really great study that was done looking at parental perspectives on children with obesity. And there are some really interesting things that came up. In particular, a variety of ways that they want their children, their weight, how they want their weight to be called, what words are positive and not positive. And these are things we can talk about later. But one thing I want you to see more than anything else is their perspectives and how they would respond if they felt that their child was experiencing stigma from their provider. This is what they said. A third of them said, hey, I would have my child go on a strict diet, right? That's not what we want. Number two, a third of them said, I would have us seek a new doctor. I don't feel safe here. And then about a quarter of them said, I would avoid future appointments with that doctor. Are we providing an environment of recognizing a patient's humanity, recognizing dignity, or are we creating an environment that doesn't welcome families to come back to our clinical settings? This is a very triggering image for a lot of individuals. And the reason why this is very triggering is because it oftentimes reminds us about our journeys, our experiences. Oftentimes I argue with patients or with my colleagues and say, what is our goal in what we're doing? Are we trying to reach a cosmetic standard of thinness and quote unquote beauty? Or are we trying to achieve health? Is it cosmetic thinness or is our goal health? I would argue oftentimes our approach to this topic of obesity is thinness, and not achieving the health of our patients and our families. If we're going to do this the right way, we have to flip that model on its head and recognize that the number doesn't tell the whole story. I'll leave you with this quote from one of my students that really captured the importance of our role. It's long, so I apologize. From childhood to adulthood, I have been obese. I was never fond of the term and the negative connotation that came with it. I was constantly told by doctors to lose weight, to keep food diaries and see a nutritionist. I hated every aspect of it, the constant comments from families, the never-ending advice from pediatricians on what I should do to get rid of that layer of fat, my own self-loathing of my body and the biases people seem to have when they first met me. I've never personally realized the toll it took on me until I lost the excess weight on my body, about 100 pounds. In my early 20s. Suddenly it seemed like I was worth people's time. My opinions seemed to matter more, and the doctors praised me for my hard work. However, what no one seemed to realize was that my weight loss journey did not give me a healthy relationship with food, or better yet, control over my nutrition. The way I did it was through starving myself, only eating small quantities once a day and running on a treadmill for 2 hours every day. When I reached my weight goals, my joints seemed to be giving out on me. I could not get up from a chair without even everything around me instantly going black and feeling like I was going to lose consciousness. It was then that I wish my doctors asked me how I lost the weight and counseled me on how even with the fat melting off, I was not becoming healthy. I was essentially depriving my body of the nutrients it needed. I was only counting calories and not looking at the nutritional aspect of what little was going into my body. And I think my doctors never thought to ask because of the stigma that surrounds obesity and the physical aspect of it. Once they saw that the fat was gone, they assumed that their job was done. And sadly enough, to this day, there is a mental block in my head where I believe that the only successful way to lose weight is to deprive myself of my basic needs to the point that I no longer care to be healthy or look fit. We all have our own perspectives on this topic. We do not come in as blank slates. We have lived experiences. Our patients have lived experiences. We have to realize where we're coming from, check our own biases, and do this well. Now, I want to give you a few examples of posture changing. And I promise to get off the stage, Mark. Oh, yeah, I'm good? Okay. All right. Beautiful, beautiful. So I'll take my time on these so I can really let them penetrate and you can understand them. Let me give you 10 strategies, 10 mitigation strategies, 10 strategies to change your posture to one of empathy. How do you do this well? Let's start. First thing, we want to start with this. Increasing our personal and collegial awareness of our own biases. If we do not recognize our own biases, we're not going to realize how we're harming our patients and our families. How do we do that? One of the ways you can do it is taking the simple IAT test. It's free. It's Harvard website. You can just type in IAT. You can see it, and you'll see that you probably have significant bias. And yeah, you can argue, well, this test is not super accurate. I took it again. The results were different. That's not the point. The point is to realize that if you have bias, if it may exist, where could it come from? What could you do about it? How could we check ourselves before we harm the health of our patients? Number 2, you want to train your staff and colleagues. Everybody needs to be aware of the role of bias and stigma. Everybody needs to be aware of how we treat patients and how those ways in which we treat patients can actually cause more harm than good in our staff, our colleagues, our patients. Number 3, you want to incorporate personal narratives and experiential learning opportunities when you can into training. Every year with my students, I bring in experts which have lived experiences with weight gain. Individuals that have experienced weight gain, have obesity, and are in medical settings and have shared with us what? Their perspectives, how they've been influenced, how they've been treated poorly in healthcare, and as a result have felt abandoned. It's an important aspect to bring in. Maybe it's colleagues, maybe it's your own selves, maybe it's family members, maybe it's patients. Lived experiences tell amazing stories and sometimes more powerful stories than the data itself. Number 4, recognize the complexity of obesity. Get outside the mindset that obesity is simplistic. We have to understand it in the complex way that it actually is that we've talked about today. Number 5, respect the autonomy of the family. Actually, let me highlight one more thing, because I think this is powerful on number 4. If you recognize the complexity of obesity, then you don't get stuck with believing, well, why are we using medication? Why are some people taking the easy way out and getting surgery? Why are we doing these things when all you have to do is what I've done for my own health? Look at me. Understand the complexity of obesity. Quite complex. Number 5, respect the autonomy of the family. You saw this image before, right? Some families may not be in that state to want to address weight in that way, and that's okay. Focus on the health, period. That's what we want to do. And in fact, what we want to always do is make sure that we hyper-focus on health over weight, right? One of the quotes that I like to use is the goal must be health and not making kids with larger bodies look fit. The goal is not making kids with larger body look thin, but the goal is achieving health. Now, sometimes weight itself, as we talked about, can be harmful to patients for a variety of reasons. But overall, our focus has to be health no matter what. Number 7, establish an equitable environment. What does that mean? Do you have blood pressure cuffs at the right size to meet patients of different weights? Do you have chairs that can allow individuals to sit up and get down? Do you have gowns that are available for patients with different body sizes? How do we create an environment in our clinical spaces that is welcoming to patients and families? Number 8, we have to commit to person-first language. You've heard me use terms like today, persons with obesity versus obese person, recognizing human first before disease, right? It's a very hard change to make, but it's something I encourage you all to consider when talking to colleagues. Clearly, talking to patients is different, but talking to colleagues, try to use person-first language. It's something that we have really done a great job with at Children's as well. We've done a QI study over the last 18 months. Actually, we're at year 2 now, where we've talked about this, how we change some of the words we use in our charting, how we change some of the words we use when we talk about patients. Words like buffalo hump instead of dorsal cervical fat pad is still in the electronic medical record, right? These terms should be removed. These terms are not okay. Morbid obesity versus severe obesity, right? There's certain things that we can do better in how we talk about this with our colleagues and with each other in general. Number 9, beware of stigmatizing images. If you're gonna use images in your practice, don't use some of those images you saw earlier. I have some images here if you want to take a picture of this as well. A lot of different websites have free images you can use with patients of different body sizes that are living day-to-day life. They're eating, they're cooking, they're walking, they're having fun, they're enjoying the day-to-day life. This is something we don't often see, but it changes the narrative to understand people and understand the humanity of people. And lastly, number 10, I'd be remiss, I see Dr. Beers in the back, if I didn't highlight this. Advocate and take the pledge. What do I mean by that? We have to advocate to disrupt systems that worsen the health of patients and families. Food security, food injustice, right? We can think about those patterns. Housing injustice, transportation issues, all of these things that add stress to families influence the health of our patients and families. Racism. Advocate, using our voices, stepping outside the 4 walls of our clinical spaces and using our voice. And lastly, take the pledge. This is one I do with my students every year. This is a powerful paper that came out, the Joint Consensus on Ending Stigma of Obesity. If you look here, this is a pledge that I ask all my students to take together. It says this: we want to treat individuals with overweight and obesity with dignity and respect, to refrain from using stereotypical language, images, and narratives, to encourage and support educational initiatives, and to encourage and support initiatives aimed at preventing weight discrimination in the workplace. We can do this in a different way. It's going to require a frame shift, a paradigm shift in how we think about how we engage our patients and our families, recognizing that health is the number one thing that we should be trying to achieve, meeting our families where they are, not trying to get our families to some superficial place that we think they need to be. I want to end right there and thank you all for your time today. And we have an exciting lineup for you today that will dive more into these topics, but thank you all for your time.
So, as you can see, Dr. Kofi Essel's a rock star in terms of translating words and guidelines into sort of meaningful change for families and our practices, and that's sort of what today's about. You know, guidelines are one thing, but actually being able to do something with them is a whole other sort of thing, and that's in part where we're really trying to go today.